I have to start with a confession, which is that I have too many slides. The good news is that I have a plane to catch, so I can only go over by a few minutes. I also wanted to point out, like, there's some people on my team who are here. If I have to leave and you had a question that I couldn't answer, maybe they could raise their hand. Yeah, these people, these four here, know a lot about what I'm doing, and they could answer your questions, and I'm also happy to take questions by email. So let me tell you a little story, which is about 10 years ago, I decided to drastically change what I work on. And this was actually influenced a lot by rejection, which was, I was studying health anxiety, which I thought was fascinating. I thought it was great. But CIHR didn't think so much. And so after a few rounds of not getting research, they didn't really like that type of research anymore. I decided to do something completely different, which is to try and work with the health system, so my health system partners, to improve the healthcare system, specifically the gaps in care. So what we know in Saskatchewan is that mental health problems are very common, and they're disabling, but unfortunately often undertreated for various reasons. So things like stigma, location, time, rural and remote location, disability, all sorts of things. And so I just decided that I wanted to work on trying to fill some of the gaps in care, and became interested in internet-delivered cognitive behavior therapy. Do you know about internet-delivered cognitive behavior therapy? Could you raise your hand if that's a new idea to you? Okay, a few. Excellent. Okay, well, I'm going to just backtrack and assume that you don't know about it. So for those that you do, make sure that we're on the same page. So about 10 years ago, what the research literature was showing is that this form of therapy was actually pretty good. That in research trials anyways, that we were getting pretty good outcomes, and people seemed to be quite satisfied with it. But what there wasn't available was there was this gap between this research and actually getting into clinical practice, and there's actually still this gap. Other than in Saskatchewan, there's not a lot of provinces that publicly fund ICBT and where it's accessible for free for clients. So in this form of care, what happens is clients, what you try and do is give them what you would normally do in face-to-face treatment and put it online. So the same types of information that a therapist would share face-to-face is put into engaging materials and shared online. It's shared usually in the form of lessons over the course of several weeks. And in addition to that, it's often paired with therapist assistance. So it doesn't always have to be paired with therapist assistance. In fact, sometimes it's just delivered all on its own, like a self-help course or a self-help book. But what we know from the research literature is that when you pair it with therapist assistance, you actually get better completion rates and better outcomes. And so I was particularly interested in, well, how do we get this happening in Saskatchewan, and doing research on that particular issue. So this talk, what I want to share with you is a bit about how I went about doing that, how I made that into a research project. I hope in the talk, though, that you'll also get maybe some ideas for patient-oriented research and see how it can kind of vary in terms of how patient-oriented research is. And also, I hope you take away from this the benefits of patient-oriented research. I'm specifically going to share with you 4 examples of research that I've done and show you sort of how they vary in the degree to which they're patient-oriented. Okay. So to go about taking ICBT from a research idea and a good outcomes into practice, I looked at the literature around how do you actually disseminate new clinical methods. And what they really show is that a facilitation unit is really helpful for this. So we created the online therapy unit for service education and research at the university. And so with this unit, we do 3 things. First, we offer the service, which I'll describe. Second, we offer education to graduate students and to community clinicians on how to deliver the service. And then we're doing research about that ICBT and how it's working so that we're continually improving the process. And this is particularly important with a new treatment like this. We can't assume that when you build something like this, the first thing that you build is going to work. And in fact, what we've noticed is that we've had to do what I call experimental tinkering or tweaking as we've gone along. And that's where the patient-oriented research actually really comes in handy in terms of really learning about how do you tinker and make this even better. So, so far, as was mentioned, we've worked with over 5,400 clients, so that's in the screening process. And with those clients, 78% of them we've been able to accept the treatment, and 22% we've helped navigate the system and look at what alternative services are available. In terms of our service delivery model, most of the clients are treated by therapists who work in our unit, so about 70%. Mike actually right here is a current practicum student that's learning this approach. In other cases, though, we've gone out and trained clinicians in the community, and they've been the service provider. So we do the screening, and then we match them with a community clinician. This is just a heat map that shows the number of clients and sort of where they're coming from in the province. So the upper part of our province doesn't have a lot of population, but you see that we are getting clients throughout the province. This is something that we're really happy about. So previously, before I had this big rejection by CIHR and moved into this area, my outreach and the number of clients that I would work with was very limited, very small area. And so this is very gratifying to see the ability to access lots of people. So the way this works is clients find us, they come to our website, and on that website, they complete an online screening, and then from there we do a telephone screening. Say most of our clients come through a physician referral or a mental health care referral, but some come from family and friends as well. Through that online and telephone screening, we're basically looking at who's a good fit for our service and who might not be a good fit and should we refer out. So when we're not taking a client on, it would be that they're at higher risk, especially for things like suicide, and we feel like a face-to-face service would be a better fit. Once they are matched with us, we give them a username and password where they go onto our website, and that's actually where they're reviewing the materials and where all the emails are exchanged to keep the information secure. And that's actually thanks to the University of Regina that we've been able to develop this web application. In terms of courses, when they come to our unit, we look at what's the best course for them. So we currently have 3 ongoing courses. One is for depression and anxiety, so symptoms mild to moderate, even sometimes into the severe range, as long as they're not at high risk. We have a course on chronic pain, so for people who have pain, but also have some depression and anxiety that are resulting from the pain or making things worse. And a course for chronic health conditions, so basically helping people adjust to chronic health conditions. And then occasionally we'll offer other courses, and these are sort of largely determined by student interest and what we're working on. So we have a spinal cord injury one at this time. So all of our courses are offered in Saskatchewan are offered with therapist assistance. And the degree of therapist assistance is something that varies a bit from trial to trial because it's something that we're really trying to figure out. What's the level of assistance that clients need? So we've done a lot of trials to date, and like I said, I want to tell you about 4 of them. What was interesting to me when I started to prepare this talk is just to think about the degree to which these different trials from the very beginning to now are, I would consider, patient-oriented, and sort of what my score would be on being patient-oriented. I just want to say, I think that most people here would know, this is the definition of patient that's used. So an overarching term, inclusive of individuals, with personal experience of a health issue, and informal caregivers, including family and friends. So that's who we're working with. I should mention that we don't work with clients who've been our former clients, but people who have had mental health concerns who are interested in being on our working group. So this is where my research is varied. This is the definition of patient-oriented research that comes from the strategy for patient-oriented research and the patient engagement framework. So the extent to which my research engages patients with partners, works on patient-identified priorities, on outcomes, is multidisciplinary, and works to improve the healthcare system and practices. So there's this tool, which for those of you who are researchers and you're applying for a grant or if you're doing research, if you haven't seen it, that's developed by SCPOR that basically you can use to evaluate, oh, how patient-oriented is my research? And so in my last grant, when I was applying, I found that actually pretty handy. But I went back in retrospect to look at what my scores would be. And so this is what, when I started off, I get 50%. I go up to around 60%, then over 70%, and now at 90%. That's where we're at, and I'm just going to explain to you the different approaches and why it wasn't as patient-oriented as it could be. So this first grant was about the very first one that set up our unit to try and disseminate ICBT in Saskatchewan. It was a Partnership for Health System Improvement grant, which means that we were partnering with the health system and researchers to try and improve the health system, specifically mental health care. And for this particular grant, actually patient-oriented framework hadn't even been put out there. So this didn't influence my research plan at all. So the question that we were trying to answer is ICBT, which is what I'm calling internet-delivered CBT, effective when offered in routine practice? And we were specifically interested in the effectiveness of 3 different programs. So how effective would it be for depression, for generalized anxiety, and for panic? And in this case, each of these programs was 12 modules long, and they were offered with weekly support. And our questions basically were, would there be uptake if we offered this? What would be the completion rates? What would be the symptom improvement? And would patients be satisfied? And we also wanted therapist feedback on this process as well. What we found afterwards is some kind of key findings. First of all, we did get some uptake. So in the first couple of years, we had 343 clients. 50% of those clients completed 12 modules, and it took them 25 weeks. So we thought it might take 12, but it took actually double the time. And we got, for those clients who completed really large effects for anxiety and depression and moderate for panic, we did have really good satisfaction for clients, whether they completed or not. What we found with this process is a couple of concerns with the program. So although it's working for lots of clients, for some, it's not addressing the fact that people often have anxiety and depression. They often go together, or anxiety and panic, or panic and depression. And our programs were very singular. A second thing is that they were very long, and they had too much information. So I guess the question that I have, so when I give myself the score on here, I actually am doing quite well within that patient-oriented framework of suggesting that research should be multidisciplinary, because we have multiple disciplines like social work and psychology and public policy and computer science, nursing, etc., working together. And we are really focused on health system improvement, but we don't have partners. We didn't have partners to start with. They haven't identified this priority, and they haven't been involved in outcomes. So I guess the question is, could that research look different? Well, I guess we'll never know, but might have it been different if I'd had patients look at these materials in advance? They might have looked at them and obviously said, this is too much. This is not addressing comorbid concerns. We don't know, but that's kind of the assumption of patient-oriented research, is that if you get them involved, that you might actually have something better that you could test. So there's my 50%. So, you know, as an academic, who wants to tell you that I got 50%? I'm putting it out there. So we moved on and decided that we wanted to continue in this area, that it was promising that 50% of our clients were completing the modules and were getting good outcomes, but maybe we could overcome some of the barriers and do an even better job. So we apply again to another grant, a partnership grant, and this time we decide that we're going to test a transdiagnostic program. So this is a program that allows us to treat anxiety and depression in the same program. We don't have to have a singular program. And we also want to test a program that's shorter in duration. So in this case, it's now 8 weeks, but we don't want to get rid of all that extra content that we have in our other program, so we offer extra resources. I should mention that this particular program, we didn't start by developing it, nor did we develop the other programs. We've partnered with people who've done research and research trials and then worked on the dissemination within Saskatchewan. So in this grant, basically, we're looking at how good is this going to be, and are we going to get better outcomes? The other thing that we did, though, was we started to be influenced by this framework and by CIHR policy. And we basically decided we would have our community advisory panel. And so they joined our team, but not before the grant, but after the grant was started. And we started to meet with them 2 times a year, and we worked on letting them know what we were doing and consulting with them and getting opinions. And so starting to take into account this feedback. Ultimately, what we found is that we have a 78% completion rate, so that's much better than 50%. And we're seeing significant large reductions in depression and anxiety in our clients. And we're also still getting really good satisfaction. So this is something that's very encouraging. There was other parts to this research, but this is kind of the main piece around patient-oriented care. And we're finding it helpful to work with our patient partners kind of to inform the process of what we're doing in terms of our recruitment materials, in terms of interpreting our results and thinking about next steps. The other thing that we did with this particular grant that takes it to another level of patient-oriented is that we really focused on trying to get client feedback at the end of the program and really try and understand what is it that clients like about this program and what are the challenges. And that makes it much more patient-oriented as well. So in this way, what we learned is that they love these general lesson materials. They like what they're learning about the strategies that we're offering for ICBT. And these materials we also include a lot of patient stories. And they like those stories, but they'd actually like more of those and see more diversity. They also like downloadable guides. So this is important. In our previous program, you had to look at everything online. And what our clients told us is that they like to actually be able to look at it online, but keep it long-term. Some of the areas for improvement that they gave us, though, is that they wanted greater flexibility in the amount of time. We give them 8 weeks on that course. And they also wanted greater flexibility in the amount of contact. So up to this point, we've really been studying once-a-week contact, once-a-week support from a clinician. And that usually takes the form of they're emailing during the week, the therapist logs on a designated day and responds to those emails. And then in addition to that, they'll pick up the phone and give a call if the client asks or if there's a higher severity rate. But basically from this, we're learning about some ideas that will make this better in the future. So here's my rating on this project. So we have patients who are involved, they're consulted about the research priorities, they're consulted about outcomes, we have multidisciplinary teams, and we're integrating into practice. So, but still 64%. So there's better, we can do better. So this is our current project grant, and it's currently underway. So I don't have a ton of findings to share with you, but I can share with you a little bit about how we're going about this project. So again, we're working with the same community advisory panel members, and some of them have stayed the same, and some have retired and gone on to other things, and so we've had other new members join. So we're still meeting twice a year, and we're informing and consulting, but they've been involved from the very beginning of the grant and had more influence and impact on the actual grant. Lots of change here. In terms of what we're looking at, we wanted to address those suggestions that we got from our patient partners. So we looked at adding more stories, adding more information about trauma. That was a gap in our current program. Giving them access to materials longer term. And then we're doing a series of trials that help us understand therapist assistance. So for example, once a week contact, what are the benefits of that versus a 1 business day response? Or once a week contact versus optional outcome. We also have expanded our patient-oriented outcomes in the sense that now our primary focus before, our primary outcome measures have always been on symptom improvement. But from our patient partners, we really learned about a couple things. One is they want greater attention to functioning and quality of life. And a suggestion from them, but actually also comes from the research literature, kind of showing a parallel sometimes between research and patients, is that they wanted to know longer term, how are we doing with the results? So we're doing now a 6-month and 1-year follow-up. Previously, we'd done 3-month follow-up and saw that our outcomes are maintained at 3 months. So that's where we're at. I can tell you one of the pieces that we look at right now is that it doesn't seem to get any better care with 1 business day versus standard, but we still have to tease that apart a little bit to see if maybe there's certain clients where that one business day response is better. So here now I'm up to 75% on this particular research. So patients are more involved, they're collaborating more, and that's what's upping the score. So, which brings me to my current research, which is funded actually by SCHRF and SCPOR, and we just got the funding, so all I can do is kind of tell you about where we're at and where our plans are at. So this is a patient-oriented research leadership grant, and what we were trying to do with this grant is get that score up. Like, let's really try and do patient-oriented research, so from 75% to something over 90%. So really trying to embrace the idea that patients will be active partners in the health research, and that's going to lead to better improvements. So when I started off in this area, and it's an ongoing process, so of course I still have more questions that I'm asking and trying to answer as I go along. But these are the questions that kind of came to me. Will patients be interested in being research partners? Will I actually find people who want to partner on this particular topic? How much time is reasonable? And how should we go about partnering? Once I partner, will I actually be able to, and really, really partner, will I be able to address their ideas? And how much longer is this going to take? How do I build a research timeline within the timeline that I'm given by the granting agency, given that I haven't done this type of research before? What are the extra outcomes that they'll want me to look at? How will data collection be different? How will dissemination of findings be different? And what will the patient priorities be following this grant? So these are just some of the questions that I've asked myself, and I have a few answers that I'll share with you in a couple minutes. So this is our patient-oriented research team. And we got together and started to work as a team even before we applied for a grant. And when we worked together on the grant, we basically decided to focus on two priority areas. So what we wanted to do with this grant is basically develop and evaluate two new programs. So one is an alcohol change course, so basically ICBT for helping people deal with alcohol problems. And the second focus was on enhanced sleep materials to our current course. And so this process of coming up with the ideas very much more involved consultation and collaborating with our patient partners. I should say, though, that they're not completely ideas that were formed by that group. So I think that could be sort of a next level of where you only do an idea that's generated by them. But we worked collaboratively on this, and we were influenced, though, by a number of things. So Ministry of Health really wanted us to work in the area of alcohol change. We had done literature reviews on ICBT for alcohol use, and it was suggesting this should work. We've done stakeholder interviews, and they were supporting our direction in this area. And then when we looked at our current clients, 20% of them are reporting significant alcohol use problems. And it's one of our exclusion criteria right now, is that we're excluding people if the problems are more of a primary concern or significant. In terms of sleep, this was informed a lot by looking at our data as well and patient feedback. And so what we noted when we look at our information from patients is that a huge portion of them come in with sleep problems. And at the end of treatment, a number of them continue to still have sleep problems. And from the literature, we know that this actually is something that we could do better. Anyway, so we collaborated together to work on these priorities and set the questions and the design for the study. And then sort of this is our plan going forward. So now that we have our committee and our research priorities, we're working on material development and selection of outcome measures for two measures that have really stood out to our patient partners so far. One is around self-efficacy and social functioning, so outcomes that are important to them beyond symptom improvement. We're looking at conducting feasibility trials, so once our courses are developed, and then working together, especially on recruitment, is what we see as our patient partners as being very involved in. And then reviewing and interpreting findings and disseminating findings. So something that is of interest to our patient partners, it especially is not necessarily the peer-reviewed publications and conference presentations, but the idea of some small videos and more engaging materials that would inform clients about our products. Some other things that you might want to know. Oh, I'm just flying through this, talking fast. So some other things that you might want to know is, in terms of our patient group, we have 4 patient partners, but it's also on our team we have 2 therapists, and so we've put therapists on our team as well. So these are online therapists, and we think this is an important piece to our research group as well. With 2 managers of within the healthcare system, 2 trainees, and 2 research associates, and then me. In terms of our payment, we have a patient honorarium, and that's been set up, and we're following the guidelines by SCPOR, which is really handy. Before this, in our community advisory panel, we were always wondering about what we should be paying people, so it's really nice to have specific guidelines to go to. We have established very formal terms for our working group that we've worked on together that we feel comfortable with, along with goals and timelines, which I think is really important in order to make sure that a project still will meet the timelines of your grant. In terms of frequency, what we worked out so far is monthly meetings, although we see this as being a bit dynamic. So over time and at certain points in the project, it may not be monthly. They're active collaborators on the project, which means that it's not just about coming to a meeting and discussing ideas at the meeting. There's actually things that people do in between meetings that they're involved in, and that's by choice, things that they are interested in. In terms of decision making, what we've said is that it's by consensus, and it involves really recognizing that experiential knowledge will get greater weight. So their knowledge of these difficulties and of the healthcare system are really important to our decision making. So in terms of where we're at right now, we started and we've made sort of the first steps that we're taking are around our alcohol change course. So like our other courses, we've started with previously developed materials. So there's a program that was developed in Switzerland, was translated into English by a researcher at University of Manitoba. And it's specifically designed for ICBT for young adults, and it was 12 modules. So we started with that, and then our research team really worked on taking what we've learned from our patients in the past and putting that program within our own model. So some things that we did was, we know that our clients prefer an 8-week course, that actually is a more reasonable course than 12 weeks. And gradually sharing information over time rather than giving people everything all at once. We've also enhanced the information from our review of the ICBT literature, and we've made sure that the information is downloadable so that they're not stuck with looking at the internet to get the information. And we've really worked on diversity in stories, so it's not just focused on younger adults, but so a wider age range, greater cultural diversity. So those are 2 things that we did on our own, and this is worked on a lot by Christopher Sundström, who is here from Sweden. So I wanted to give you an idea of what happened. So this is kind of an example of a sheet that we gave them. So this would normally appear on the website, and so we've taken this to our patient partners and asked for feedback. So I just wanted to show you a little bit of what value you get from working with patients. So that goes to this. So they really highlighted that this is hard to read and doesn't have the information stand out. So making standout boxes, more bulleting, so more bolding, more blue. This, again, so we give them this, and then it turns into this. And this turns into this. So this is an example of where they felt like this is not enough information. So it's not just about format, but about content. What else do they feel like we should have? So extra information. This turns into this. So more diagrams again. So this is an example now where I'm at 92%. So we have equal partners on our grant. They're collaborating. I still gave myself a 4 on research priority because I think that could be different. And they are working with us on research outcomes. And then this is I'm anticipating, so we'll see how that goes. Assuming all goes well. So to come back to the answers to those questions that I asked, first of all, I was surprised at the patient interest. It wasn't hard for us to find patients to partner on this topic, and to be happy to do that. Once a week, or once a month, that might be too much, well, that's another study. Once a month contact seems reasonable. This team process of meeting once a month, but then having activities in between seems to be working. And the other thing that I'm finding is that, yes, we can address their ideas. It's not like I'm going to be given some ideas that we wouldn't be able to address. And I would say that it does take more time, but from our experience, what we're seeing is that this is making a difference. And we think it's actually going to save us from doing the whole study and then getting that feedback on the back end. So as I mentioned, they've come up with some new outcomes that weren't ones necessarily that I would have highlighted. And moving forward, we still have some questions that we'll have to address. So I remember the first picture I showed you was about gaps in care, and this is the end result of what I think happens. Well, first of all, when you work on a project continuously and you keep trying to refine it and improve things based on patient feedback, I think you get closer to getting a good product. And then by partnering with patients, you also have a greater likelihood of doing something that's going to make the road better. I'm not saying that this is where we're at fully. We have ways to go, but I do think that that we are making a difference in terms of filling some of those gaps in care, and that's where we are moving forward. I want to acknowledge the many people that contribute to this unit. So we have a lot of researchers at the University of Regina that do research in the online therapy unit. We have many international collaborations and Canadian collaborators. We've had really good support from the Saskatchewan Health Authority and all the community mental health clinics in referring clients and in training therapists. And then we've had very good fortune of getting funding for this type of work. From people, the current people on the team, and then coming back to our patient partners and the great work that they're willing to do with us on this project. That's it.
All right, so we'll just take questions now. I think we have 2 minutes for questions. If anybody in the room has any, and then we'll monitor what next questions as well.
How did you go about recruiting your members for your panel, your community advisory panel?
Yeah.
And I guess maybe we'll repeat the questions
Okay.
into the microphone for WebEx if that works.
Okay. So the question was, how did we find the patients for our patient advisory group or community panel? So it really, there's an interesting thing as a psychologist that you actually don't want to work with your former clients. You're not supposed to have this dual role. So I didn't feel comfortable asking people who'd been part of our treatment program. But what we did was we reached out to some different organizations. So we started with Saskatchewan Community Mental Health Association and asked for referrals from them. Within our own unit, people were involved in different organizations and would ask or tell people about the project. And so I never did the actual invitations myself. It was always through contacting somebody who would tell them, and then they would contact us to say that they were interested. Yeah, and then sometimes people were, there's a couple examples of somebody who's known, who does advocacy in the area, and we're working on on our general community advisory panel. So it's openly acknowledging a problem, and then somebody from the unit would call and say, would you like to be part of this group? Yeah.
I just have online questions coming in. So do you ever have face-to-face contact with the participants, patients at any point in the research, i.e. Skype, Zoom, or FaceTime?
No.
Okay.
No.
Second one,
okay.
and I'll head over to the rest of you for more. Have you ever considered an online chat
So we've looked at the literature around that, and there's definitely people who are doing it, and we just haven't done it, in part because it hasn't been something that stood out from our patients or from the people that we're working with as something that they want. So occasionally you'll get a comment like, I would have liked to connect with so-and-so, but it's not like a primary theme. So I wouldn't rule it out as something going forward, but really the research has very much evolved from dominant patient feedback.
Therefore, from my understanding, then there is no face-to-face online. It's
No.
It's homework. It's discussing how that went for the week through via email.
Yeah.
Okay.
Yeah, so what happens is the client is online, they're reviewing the materials, and then they have secure email they send to the therapist. That's the predominant way. And then occasionally, we'll pick up the phone and we'll give a phone call. And it's usually around like somebody who's having difficulties or challenges, and they want a phone call, or there's been a spike in risk of suicide, and then of course there's a phone call.
Sorry, I'm not done.
Yeah.
Thank you for doing this. We have a lot of gaps, and I'm just coming back from burnout. We need more out there for sure.
Thank you.
Yeah, no, really, thank you. We all need the help, and you know that. And that's sort of we're using where our technology is going to help us and help others in the mental health, because it is really so stigmatized. And then one more question is, eventually, do you think you may look into other modalities of therapy? Like CBT or something for like personality disorder or?
Yeah, I mean, I wouldn't. I would not rule anything out. We have looked at, every time it's time to apply for a grant, we think about different issues, and sometimes it's really, this is an example of where our funders have such a big impact on what we do as researchers. So if you want to do research, you kind of have to look at what's being funded.
Yeah.
And that also is definitely a driver.
What's sexy
Yeah.
for that year in the fiscal year.
Yeah.
Gotcha.
And then also, what's within our area of competence and capability. So again, like my primary area before I did this was anxiety, depression, and cognitive behavior therapy. So I'm like, this makes sense for me. And as I get other people who come on board and do online therapy, we've had some other researchers who've looked at different things. So we have somebody who works with parents, helping them learn about childhood anxiety. We have somebody else who wants to do compassion as an intervention, as relapse prevention for depression. And so we're collaborating on that project. We have a new project that's coming up that's funded, and it's really focused on public safety personnel and really trying to meet the needs of people who are have difficulties getting care. So yeah,
Thank you.
multiple factors. Yeah.
I'm glad you said that about the parents and the kids who go to a community pediatric rotation. We see lots of children in kindergarten with stress and anxiety. And that's kind of the major fear, to be honest. But we see, can you talk a little bit more about that with the parents and the children?
Yeah. I'm just looking to see if there's anybody on that team who's here. So it's basically still under development and being researched. The basic idea is that the parents who are approaching Child and Youth Services in the Saskatchewan Health Authority who have children who have anxiety are told about the program, and then if they're interested, they go through a screening process, and then it's the parent that basically learns about anxiety and how to work with the child, and then the parent helps the child. Basically, the parent becomes the director of the service, and the therapist is there to support the parent in helping the child. So it's kind of an interesting model. Yeah, and right now it's about the materials were developed, and they're looking at the reach and the outcomes and satisfaction. But the trial is underway. Yeah.
Can you talk about the size of your panel and kind of what an ideal size is? Like, when you get that many people in a room, do they disagree about things or?
Yeah. So I think that's an excellent question, and I would love to see kind of more research that would help kind of inform that, and I bet it depends a little bit on the topic and the clients who are involved. In our case, so we have the groups on our grants, that it's a large group and we're just meeting twice a year. Our group is larger in terms of the number of patients who are involved. I think we have 8 partners. And that seems to be fine at that level. I thought with this grant, I purposely kind of went with 4 partners, feeling like with these particular projects, that might be a better kind of number to work with. Like if it got too big, you don't have time to really, get the feedback of the people. Whereas I felt like if we have 4, like we can really, get their feedback and have time for that. But honestly, like I don't know that I have the answer to that. But I think it's this whole area, and even like with ICBT, I really think that it's a bit about tinkering and figuring out what's working and not working, and trying to learn from what you're doing.
Just to let you get out of here, I think we'll take 2 more questions.
Okay.
And then we have one back there and one from my back.
Mine's related to the previous one. Just how do you minimize the power dynamics on that?
Yeah. So I feel like that's a great question, except I don't know the answer because we just haven't had that come up so much. Yeah. But I do think that there's one thing about it, and that's that we do have terms of reference that are there in advance. And I think a second thing is that we do have the opportunity, there are maybe some members who are a bit quieter, but they have an opportunity to share feedback in between meetings, to, they get the materials to write their own comments on it. So you might have a couple of patient members who are more vocal in a meeting, but the other members are still voicing their opinion. But I haven't really had I think it's a great question of what if you have a patient group where there is a lot of tension and power dynamics that you have to manage. Yeah.
So I have one comment from WebEx, and thanks to our WebEx joiners, we're obviously really engaged today with the questions and comments. So excellent summary and many improvements from where we were involved in 2014. So congratulations on that. And then a question around primary caregivers, and I know you talked a little bit about parents, but I'm thinking this might be referring to other than sort of a parent. How are primary caregivers involved in GAD situations? The SHA has a PSCC protocol, that's Patient Family Centered Care Protocol, but I haven't seen anything on family or caregiver involved. Suggest a part of research should cross-check caregiver observations with patient observations in terms of feedback on what is previously has progressed.
Yeah, I think those are great comments and great directions for sure. There's a couple things that I know from our clients that some clients, as they're working on it, there's nothing that we say, like if you're working on it and you want to share and get your caregiver involved, like that would be completely fine. And at different points in the course, I'm just thinking, especially in our alcohol course, the one that we have coming up, we really talk to them about having your support system around you and talking to your support system and looking for ways. So within the materials, it certainly suggests reach out to the people who are there and ask for help. And we don't not support it, but I think it's a great idea about trying to get more feedback from caregivers about the outcome. Yeah.
All right, I want to say big thank you to Heather then for